Hey guys, Woodruff here. So let's talk about blood clots. So these have a lot of fun names because why just name something once when you can name it 3 times or 4 times? This is a part of my larger vascular disorders lecture. I'm breaking up into smaller parts. This is the one that has like interactive stuff in it as I can. But yeah, I hope it's helpful. So let's talk about VTE or venous thrombosis or blood clots. There's lots of fun names for them. But like I said, most of the time on an exam, you're going to either see VTE, you're going to see blood clot or thrombosis, etc. And what happens with what we worry about or are concerned about when it comes to a blood clot is one, when blood clots form, they can create, flow issues. They can lead to occlusions. They also can lead to inflammation, which can irritate and cause issue. And worst case scenario, they also can dislodge and go other places. Ooh, I just remembered another thing I want to add. Complications. So anyway, we definitely want to keep a close eye on these because they can become very dangerous. Sorry, last little note. If you haven't been watching my other videos, if this is your first one, just know I'm taking notes. I'm always a perfectionist trying to edit my PowerPoints. So a big thing that's usually tested over that you want to focus on is going to be risk factors for blood clots. There's what's called Virchow's triad, and it's a series of, like 3 common, kind of criteria that can lead for you being super at risk for a blood clot. And it's not that you have to have all 3. You can have just one of them and end up with a blood clot. There's general risk factors like older age, but these 3 are, what we really consider, what you want to think about. Like if you're thinking, is my patient at risk for blood clots? You can start thinking about, oh, do they meet this criteria? And so I broke it down and made it more simple because while this is a beautiful colored triangle, it has a lot of big fancy words. So let's just make it more simple and break it down. So first we have, people are going to be at risk for blood clots if they have things that lead to blood pooling in their body. So that would be people that have blood stasis or blood that's just chilling or fibrillating. Like if you have atrial fibrillation, which don't worry, just arrhythmias are coming. I know I can't wait either. It's coming up. It's one of my favorite lectures. Anyway, I know you're not as excited as me, but it's okay. You'll get there. You never know when you might fall in love with cardiac. It's a love that will never deny you. It never goes away. It'll love you eternally until your heart stops. Okay, I'm going to stop with the jokes. Anyway, atrial fibrillation is a dysrhythmia where there is pooling of blood in the top chambers of the heart because the top of the hearts are literally just fibrillating. So they end up, pooling blood. So you're more at risk for forming clots there. Heart failure, they have that backflow or of the blood. And we'll talk about heart failure is pretty cool too. Not cool if you have it. I'm not saying it's like something you want to get, but I'm saying it's cool to learn about. And the way that the heart works and stuff like that. Even though it's very sad for the heart to fail. But point is that there can be pooling of blood. Also, people that pool blood are going to be people that are immobile for long periods of time. So if I'm not moving a lot, I'm going to be at risk. So people that are like have a long-term injury or post-op patients are going to be more at risk for clots, which is why everyone in the hospital is on DVT prophylaxis. That's another term. I have VTE, but I don't have DVT. So let me add that. So add DVT for the slide. That's usually what we're talking about. Anyway, and then the other thing you want to consider is long trips. So I always tell the story of like back in COVID times, like we went to a middle of nowhere vacation and I had it was like a good 13-hour drive and something like that. And so like later on after that, it was actually a completely different injury, but I thought like I was having swelling in one leg and a lot of pain in one leg. And so they checked me for blood clots because they're like, oh, wait, like you just had a long trip. Just to be safe, let's check you for blood clots. And so they checked, even though I'm young and healthy and not on, any hormonal birth control or have any of these other risk factors, it's always good to check. So I luckily did not have a blood clot, but I had a risk factor, which is what the doctor had identified. So that's one thing is blood staying still? Is it chilling in one place? And that's either because of a heart condition, because of circumstances around movement, things like that. Then we also want to think of things that are going to increase the thickness of your blood. So this could be hormones, like people that are pregnant are going to have more circulating hormones, which can increase that thickness and put you at risk. Birth control. I always tell the story of my friend who's young, healthy, athletic, healthiest person I know, and ended up with a blood clot. And the only risk factor she had was she was on birth control. Also, trauma or surgery can increase the thickness of your blood through some of the process and the inflammation and things like that. Really, anything that can cause inflammation, like if your patient has sepsis, a bad infection, inflammation kind of tells your body, and whether you have inflammation because we're cutting into your body, you have trauma or sepsis, something like that. If you don't know what sepsis is, don't worry, you're going to learn about it one day. Complex is a lovely topic. Complex is a lovely class too. Don't worry, I got videos for those too. You're going to love it. Sepsis is kind of cool. Again, not cool if you have it, but cool to learn about. But anyway, inflammation. And when inflammation happens in your body, effectively, what the issue is that your body is like preparing for a fight. It's like inflammation's upon us, there's something going on. It's preparing for a fight. It thinks there's an infection coming on. It thinks there's something going on. So it's preparing. So one of the things that activates is the clotting cascade. So anytime there's anything that can cause inflammation, can lead to you being more at risk for clots. And then we talked about this, if you remember, in the blood disorders lecture, polycythemia, or where you have too many blood cells. So this leads to a very high clotting issues or increases the thickness or viscosity of your blood. And smoking as well increases the thickness of your blood. It also messes with the blood vessel lining as well. So it's kind of like two risk factors in one. The last part of the Virchow's triad is any damage to your blood vessel lining. So you want to think of anything that's poking in the blood vessels, like a device like an IV catheter, trauma and surgery, IV drug use, things like that as well. All right, so let's look at these scenarios, because these are kind of things that you definitely could have on a nursing school exam. So let's look at, no, that's just someone driving crazy outside. I'm sorry. It's a Friday night, so, people can be getting crazy. I always like in my head, just there's, so many ways to die. So sometimes when I hear a noise, just not sure if the UFO is coming to finally take me up or what. So when you're looking at risk factor questions, I'll give you a little hint here. All of these are going to be risk factors for a blood clot. All these people have one or more risk factors. When you do risk factor questions on an exam, you don't want to think about, if we go back to this slide, there's a lot of these that seem like big risk factors, but it doesn't matter how big the risk factor is. All we do in risk factor questions is we count them. So let's say if we have like age, gender, and then some other risk factors. Some people could have 3 risk factors, where some people could just have 1. So you want to count them. So in other words, if this was a select all that apply, I was looking at this, I would need to consider, okay, and it said who has, well, I shouldn't say if this was select all that apply. Let me break back up. Let's say that this was just a regular question, and it said who has who's the biggest risk for getting a blood clot. I would have to count, and the person who has the most number of risk factors, it doesn't matter how glaring their risk factors are, but it's about the number of risk factors they have, who's most at risk. So let's look at this first one. A 25-year-old client from United States that takes a trip to Australia. So this patient is going to, sorry, I lost my heat in bed. I'm getting old, So this patient has a few risk factors. So the biggest one in the story is that they're going from the United States and taking a trip to Australia. So if you know anything about the distance from United States to Australia, that's a long distance. They're going to have that prolonged immobility, which can put them at risk. But you can also look at their 25. And so we don't know if they're female or male, but if it's a female, I realize I have single one has female or male, so I need to update it. Update first scenario, female. Sorry for my perfectionism. So we have a female here who they could be on birth control, etc., or be higher risk, as a result of that. Trying to think if there's anything else. So I think most of it's just the stasis and the possibility if they're a young person, they also could be more at risk for being on birth control or other things, the hormonal stuff that could affect. And now we have a 36-year-old female who plays competitive soccer and is on oral contraceptives. So she is playing competitive soccer, so it's possible she could have an injury or a trauma, could lead to inflammation and put her at risk. Playing, sports is a great thing. She's getting moving. That might actually decrease her risk, but it just depends on, it says competitive soccer. And if it's competitive, like some people in my family, my in-laws, then it can get pretty serious pretty quick. Oral contraceptives or hormonal birth control also increases your risk. Then we have a 55-year-old man with a history of COPD who's on home oxygen. So some people might say, ooh, COPD is not a risk factor. And in itself, COPD itself is not a risk factor for blood clots. But you have to think about a patient with COPD. A patient with COPD is not moving as much. A patient with COPD, so they might have the immobility. A patient with COPD could also have a history or current use of cigarettes, which could increase their risk for getting a blood clot. Also, this patient's getting older, and so increased age is also a risk factor for blood clots. So yeah. I'm sure there might be more things that I'm missing in these that are even deeper if you make a story out of them. I have a 26-year-old female, again, 26-year-old female. She could be young. She could be on birth control. It doesn't say in the question, but, we always consider that. She also has type 1 diabetes. And her most recent hemoglobin A1C is 7.5. So she has diabetes, which is a risk factor, as it can break down the lining of the blood vessels. And then she also has poor control of her diabetes. Now, I know 7.5, you might be saying, well, that's not that bad, but it's still enough to be a risk factor. So we definitely want to keep it in mind. Even though she's young, she could be very at risk because of her diabetes and her poorly controlled diabetes. And last but not least, we have a 77-year-old female, so she's older. So that's a risk factor. And she's receiving long-term antibiotics for severe infection. So once she has a severe infection equals inflammation. So we already have that inflammatory part of it. But she's also receiving long-term antibiotics. So if she's receiving long-term IV antibiotics, which means she has to have either a PICC line put in or peripheral IVs regularly placed. So she can have that, access issue where because they have to insert access, she's at increased risk for clotting, having that catheter that's not hers inserted inside of her. All right, so what does a patient with a blood clot, VTE, DVT, et cetera, complain about? So there's superficial blood clots, and then there's also deep blood clots. Most of the time when we talk here, we're talking about DVTs, because the superficial ones, we usually don't need a lot of treatment, et cetera. But what they can have is, and the really big key here is it's one-sided. They have one-sided, they might complain of itching, pain, or tenderness. They may say it just, they have a sense of fullness in that area. And then as the nurse, I'm going to look on that side that they're complaining about. I'm going to look, is it swollen? Is it red? Is it tender? Maybe I want to add that. Let's see. Swollen, red, tender. I'm not usually this ADD when it comes to being inattentive about these PowerPoints, but it's cardiac, and I got to make my cardiac PowerPoints look beautiful. It's so important. But anyway, you might assess for a fever that it's possible they could have a systemic fever as a result. And just remembering that when you're assessing, we're not assessing to see that they're getting perfusion to their toes. Remember, this is a venous issue. So it can lead to backflow, the swelling, you see the more swollen leg. So I don't need necessarily, I'm not going to be horribly concerned about their pulses and stuff like that. I'm just worried about the swelling, the pain, the fever, whatever symptoms they might be experiencing. No, and that kind of leads me into, there was something else I was going to say there, but I'll just talk about it here. We want to look for signs that they're getting better, that, maybe they have decreased pain or symptoms, no fever, less swelling, they're able to get up and get moving and have good activity tolerance. But another part of the priority assessments is I want to look for what symptoms they're experiencing, but I also want to look for, is it possible that they're experiencing a complication? And probably one of the biggest complications that a patient can have when it comes to a blood clot is migration or spread, or, dislodgement of that blood clot. You have to think about a DVT is usually in the leg. You can get DVTs in other places like your arms and stuff like that too. But we usually, when we talk about them, we're talking about in the leg. And if it gets dislodged, where is it going to go? So you have to think of what it feeds into. It can go into the heart, go throughout the heart, and get caught in the lungs, cause a pulmonary embolism. So that would be Like, we'd be looking for the chest pain. It can also go through my lungs. Sorry, let me back up here, because PE can cause chest pain, but really what you want to think of with a PE is like the sense of doom, difficulty breathing, decreased oxygenation. So first thing, the clot's dislodging. It could get caught in my lungs and cause a PE. I'd have difficulty breathing, look for respiratory signs. Then it could go throughout my heart and get stuck in my coronary arteries. And that could lead to chest pain, and AKA an MI or a heart attack. Then it also could travel all the way up to my beautiful, beautiful brain, and lead to a stroke, which would look like mental status changes, one-sided weakness, facial droop, etc. There's a lot of other symptoms of stroke. We'll talk about that in the future. Stroke is like my cardiovascular like continuance in Unit 3, where it's like the only cardiovascular thing that I get to talk about very much. So it makes me some happy. It makes me some happiness. It brings me some happiness. I can form sentences sometimes. Anyway. So the other signs that a patient with a blood clot is getting worse is, of course, if their symptoms and pain are getting worse, they have a newer, worse fever, there's worse swelling, or they can't even get up and move around. And I had one of my husband's friends, he was the worst when it came to how he did with his blood clot. Like, I remember he was walking around, he ended up like, he had I don't remember exactly what happened. I want to say he ended up, I can't remember if he got like an infection, then he ended up with a blood clot because he wasn't moving around enough. I want to say it was that, but he was just like, he could not move, and he was like, oh, he ended up with a Foley, and he's like a young guy. But like, it was just ridiculous. Like, he could not move. He's like, oh, so I want to say he had some sort of bladder or kidney issue, and then he didn't move enough, and as a result of that, then he got a blood clot. But yeah, he was having a lot of issues, but it really can be so painful that they can't move. So I'm not really making fun of him, but I kind of am. Anyway, labs and diagnostics that can come with this is we really want to look for causes, and then we also are going to have certain labs that are going to help to tell us how the patient's doing with their treatment, because we're about to get into all the anticoagulants and get into some of the meds, which I know you're like, man, where are the meds in this section? So some of the labs we might look for signs of clotting, like someone might be showing based on the time it's taking to make a clot that they're more likely to make a clot. So we look at things like the APTT, INR. We can also look at the platelets and see where they're at, if they have an increased number of platelets or something along those lines. We also want to see if maybe like what is the cause of their blood clot. So for example, when we talked about polycythemia, we talked about how they have an increased number of blood cells. So I want to maybe look at their blood cells and see if they have more, just to kind of tell like, okay, what's the problem? Because I can know that I have a blood clot, but I want to also see what I can do to prevent it. Now, sometimes blood clots just happen, but if there's a preventable cause, or I can treat another problem that's leading to clots, I want to get to the bottom of it. And then later on, we may monitor the hemoglobin and hematocrit to see, not the hematocrit so much, but the hemoglobin to see, is a patient having, well, possibly both. I'll say both. We might look at both of these to see if they're having a complication of their blood clot medication, which is anticoagulation. So in other words, patients that are on anticoagulation for their blood clots are more likely to bleed. So one of the best ways to tell someone's bleeding inside is going to be checking their hemoglobin. We also want to look as if there is clot material present. So there's a specific lab, you're going to see this one just for DVTs, or VTE, I should say, not just DVTs, but any sort of clot issue. So it's called a D-dimer. And what a D-dimer tells me is that there is some sort of clot material somewhere in the body, or I have to like pretty much think of it. I like to think of it like, at Christmas when you're wrapping gifts for your kids and you don't want them to know that you're wrapping gifts, and they're like looking everywhere. If they find scissors, wrapping paper, and like receipts from a store, is kind of proof like you bought them a gift. So it's the same with the D-dimer. Like, you don't know what you might, like, again with this, they might not be able to find where the gifts are or what you got them, but they know you got them some presents because you have all of the supplies you need to wrap presents. So it's the same with the D-dimer. And maybe that's, I love that example because I'm such a nerd and a dork and a weirdo. But if you don't like it, you could just toss it away. But it's the same thing here. Like D-dimer is effectively where they're trying to tell my body that it's telling through this lab, it's telling me that somewhere in my body there are the materials needed to make a clot, or the breakdown products of a clot. And so it's saying there's a clot somewhere. So there's also, just like there's arterial Dopplers, there's also venous Dopplers. And like this picture here is a venous Doppler. And you can see this is a juicy little sucker here. Now, maybe that's not the appropriate term. It's not medically or professional about it, but it's a big old clot right here causing a pretty big blockage. But we can actually see them in the veins. So let's break down some more labs. This is going to be really helpful as we are going through. Let me add another note here. Understanding up and down. Okay. So the big thing here is that all of these labs we're going to use for different reasons. I'm going to actually start at the bottom and make my way up because I think it'll be a little bit more simple. So first there's the hematocrit. Now you might not have really heard like a lot of talk about this. We talk about an H and H. That's a hemoglobin and hematocrit. Most people know the hemoglobin part, but don't know a lot about the hematocrit. What a hematocrit really tells me is how much volume do I have. And so whereas the hemoglobin is about my oxygenation, how much oxygen I'm getting out into my tissues and stuff. That hematocrit is more about volume or dilution. It can tell you about like if someone's dry or has, is well hydrated, etc. So if a hematocrit, and it's a percentage, if it's low, it could be a sign of volume loss, because literally like if someone came and stabbed me right now, my hematocrit would be low because I'm losing volume. So I have less percentage of cells. Or what do you call it? It also could be that there's an issue with dilution. So I use the example in class about, if you make a mixed drink and if you, if you dilute it with more of the mixer than the alcohol, there's still the same amount of alcohol, but it's just diluted. Like there's more of the other stuff. Or someone else gave the example of, and this is for you, NH, if you're watching this, like pretty much ice melting in a cup of water. It's still the same amount of particles in that water, but there's just more water versus particles. Same thing happens in the blood where it gets diluted. And don't get too crazy or psych yourself out with this. You do not have to know in depth about this, but you do want to know what's normal, and it helps me to kind of talk it out. So a high hematocrit on the other side, so low would be like, oh, I'm losing blood, or like I literally have less cells, or it's diluted, like I have a whole lot of fluid, and it's like literally diluting all of the particles. I have the same amount of particles, but it looks like there's less cells because it's so diluted. Whereas high hematocrit is usually a sign of dehydration, and it's high because it's the opposite of what I just talked about, where there's a whole lot of particles, but not a lot of fluid. So the particles are staying the same, but because there's less volume, it looks like there is, it looks like there's more particles present or more of these cells present. So hematocrit effectively tells you like percentage of cells and what we like it to be. So we like it in the middle there. We don't like it to be too low because it usually means I'm losing something or I'm diluted, and we don't want it to be too high because it can be a sign of dehydration. And this is why like when patients come in and they're really dehydrated, their hematocrit can actually be like high normal, but it's really because they're dehydrated, not because they're actually doing great and have a ton of cells. So there's also the hemoglobin, which we talked about when we talked about anemia. Another thing you need to know, this is your cue. If you haven't, go back and review iron deficient, aplastic, and then also polycythemia. Remember your blood disorders. People always forget the first thing we learn every section. So go back and read it. Remember, if it's low, it's going to be anemia. Usually the normal is going to be around 12 to 18. There's also platelet count. So we've talked a little bit about this one. You'll definitely see it more as we're moving forward into cardiac. The normal for this is going to be 150,000 to 400,000. And what you want to think about this, if it's high, you're going to think of someone like polycythemia, too much clotting, where if it's low, we're going to be, remember platelets, they're that plate that help to protect my tissues. and form the plate over, my tissues, and they form a plate over plaques, which can create clots and things like that. So they can add to clots. So, but if I don't have that, I'm not protected. I can bleed more. It's not something that I'm not going to get back into it, but it just adds to the clot. So if I don't have that, if the platelets aren't sticking together as much or hanging together, I don't want to I'm going to back up, take back what I said, because I'm getting into antiplatelets. Let me say this, because antiplatelets and low platelets are two different things. But if my platelets are low, I have less of the materials that can at times stick together and form these plates that can, when I cut myself, it protects me, and it helps stop me from bleeding. It creates, and like I talked about in my class that I really love, I'm a very visual person, and there's a really cool anime on Netflix that really shows like there's a disruption, and all the platelets come and they're like, we're gonna save the day, and they create this like amazing plate of protection around. But anyway, platelets stop you from bleeding. Let me just keep it simple for those that are not nerdy like me and not get too far off track. Platelets are a plate of protection to stop you from bleeding. So if I don't have a lot, I'm bleeding. If I have too many of them, though, they're more likely to hang together, congregate and form like little clots. D-dimers, the lab we already kind of talked about. I'm not going to go too deep into that. Just know that greater than 250 suggests that there's some sort of clot somewhere. Remember, that's like, like when your kids can tell that you have presents hidden somewhere. They don't know where they are or what they are, but they know they're somewhere because you have all the materials that you need to wrap presents. All right, so now I'm going to focus on this last part, and this is where students can get very confused. So when we're talking about labs, and in real life, depending on what hospital you work at, some hospitals use a heparin assay, some hospitals use certain antithrombin labs. I'm trying to think of something else that I've seen. Factor XA. There's a variety of them. Factor XA assay. There's a variety of labs I've seen used for anticoagulation monitoring. But as we're going into treatment, we're going to talk about anticoagulation. And with anticoagulation, we want, effectively what we're trying to do is we have a person who has a blood clot. Now, with anticoagulation, I cannot get rid of the blood clot with anticoagulation, but I don't want any more clots from forming. I don't want anything more to, be getting into my system. So what I do is I give anticoagulation, but it's a really fine line. Anticoagulation makes it so you don't make clots, but it also makes it so you're more likely to bleed. So what happens with all anticoagulation, or sorry, I shouldn't say all, but with certain anticoagulation is I want to do what's called therapeutic monitoring, or I want to see like if they get too much anticoagulation, they can kind of fall to one side and they're more likely to bleed. If they get not enough anticoagulation, they're on the other side and they're more likely to clot. So I really want people on anticoagulation to be in this therapeutic range, kind of right in the center, which is going to put them at not too much risk for bleeding, not too much risk for clotting, but right in the middle. So they've determined that if people are in this range for these labs, that they're going to be what we consider to be therapeutic, or be at a level that's going to protect them from forming more blood clots, but not to the point where they're going to bleed to death. So what I'm recommending for at least people where I'm at is that you don't need to study what's normal for PTT, INR, all this stuff. You need to study what's therapeutic, because we don't really look at the norms. We look at these labs when we're seeing, is a med working? Because these tell us, is the med in the right range? We want it in this little happy place in the middle. Again, not too much bleeding, not too much clotting. We want it right in the middle. So when you're studying these, really study the therapeutic. So for our textbook, what we have is, and there is a difference between PTT and APTT, but just know when we're talking about this lab, we want the, what therapeutic is, what we want it to be is 46 to 70 seconds. This is measuring the amount of time it takes you to form a clot. So this would make sense that effectively we're measuring time till you form a clot. And so if with a lab like this, if we're getting above 70 seconds, that's taken me a long time to form a clot, which means I'm more likely to bleed. But on the opposite end of the spectrum, if I get less than 46, which, again, it means it's taking less time for me to form a clot. It means I'm making more clots. And so therefore I'm more likely to clot. What you want to consider here is that what do you call it? This 46 to 70 kind of tells me about like where they're at when it comes to more likely to clot or more likely to clot, more likely to bleed. And really, I just want it somewhere in that therapeutic. I don't want it less than 46. I don't want it above 70. Now, this is only when they're on certain medications, and we're going to get into it. There's like this, the PTT is not for all anticoagulation. It's actually only for really one medication, one type of drip. So you really, when you're studying these two, you don't want to just study them like, okay, 46 to 7. You have to know which medication is it tied to or what is it related to. And we're about to get into that. And again, if we gave you a question or something like that, it would be something along the lines of, okay, you're taking care of someone on this medication, their PTT is this, what does it mean? You need to make sure, one, does that medication match that lab? Because like we could give you a question and say, hey, someone's on this medication, their PTT is this, what are you going to do? And that lab might have nothing to do with that medication. So you want to make sure you have, you're looking at what is the lab? Is it related to the medication? If it is, what does the interpretation? Is it high? Is it low? Or is it therapeutic? And then make your judgment from there. The other lab we're going to talk about that can be used for monitoring for anticoagulation for specific medications is what's called INR. And this again has a therapeutic of 2 to 3. Now there's no seconds here, it's a ratio, but it's the same thing. If I'm above 3, I'm taking longer to form a clot, which is yay, but then I'm also a little too, once I'm above 3, it's like, oh, this is too much. I'm so much more likely to bleed. Whereas if I tip to the other side, and if I'm less than 2, then I'm going to be taking less time to form a clot. So I'm forming more clots, therefore I'm more likely to clot. So when it's too low and below therapeutic, I'm more likely to clot. When it's too high, I'm more likely to bleed. Because it's all about the time it's taken to form a clot. This will make more sense when we're going to do some scenarios. So like I said, the mainstay treatment for VTE, DVTs, all the stuff, the blood clots is going to be anticoagulation. Like I said before too, we don't break down a clot that's already there. We really just want to stop more clots from forming. We use the anticoagulation for that. So depending on the clot and the cause, the patient may need lifelong anticoagulation. So it's really going to be all about education. So we want to do good bleeding, teach them about bleeding precautions, which we'll talk about at the end after all these medications. There's 3, like we're going to talk about the new age or the new oral anticoagulants. But the main meds you're going to see given for that are like long-term tested are going to be warfarin, also known as Coumadin. And then heparin, which is regular heparin sodium that can be given either sub-Q or in a drip, and then low molecular weight heparin, which is I always think of the L as like more of a long-acting form of heparin. For all of these, we know they're working. It's going to be similar like aspirin and clopidogrel, that they're having no cardiac events. There's no MI, no stroke, no PE, excuse me, and there's also no additional blood clots that are forming. A sign of a problem is going to be bleeding. The big thing with all these is going to be bleeding. Now, some of these have also specific side effects, but instead of putting the bleeding on every single slide, I wanted to just kind of sum it up. Like overall, they shouldn't be clotting, and we also don't want them to be bleeding. So we're keeping them in this like middle place. There are some other devices that can be used in treatments to treat a blood clot. If it's really severe, really thick, there are times that we go in and we'll actually kind of like pew, pew, like shoot at it with a thrombolytic like TPA, and we like locally do that. And so we also can do what's a vena cava filter, which is like a net that catches clots. Now, it doesn't stop you from clotting. It doesn't make you less likely to form clots. All it does is catch them if they're there before they migrate to your heart. But these can clog. There's a lot of danger and safety issues around them, but they still use them sometimes, risk versus benefit. And just as a reminder, like the levels is we have antiplatelets we talked about. I have a risk for something. The P in platelets I think of as prevention. Antiplatelets are forming a plate to prevent me from being so likely to stick together, my platelets from sticking together, so that I'm less likely to clog. So then there's anticoagulants. Anticoagulants are given for patients that have a clot or are super high risk, like AFib, things like that. And then I have thrombolytics. Thrombolytics, I was joking in in my class that like a joke around the way to remember is think the T is like across, and think of this because we give thrombolytics to people that have clots in places that can kill them. So think of, you go and see Jesus, and so the T for thrombolytics is going to be, that they have a clot in a place that could cause serious injury or death. So think strokes, heart attacks, and PE are times that we use thrombolytics. So you could also think there's thrombolytics have 3 times that they're used: PE, MI, or stroke. All right, so let's get into these medications. So these are anticoagulants. So remember, we already talked about antiplatelets. That's clopidogrel, aspirin. Now let's get into anticoagulants. Now we're not going to talk about the T that I was just mentioning, the thrombolytics, until we get into stroke. But so really you want to like focus your energies. Okay, I'm at the point now, I already have a blood clot. So I need a medication. I can't get rid of that blood clot with this medication. Blood clots generally dissolve on their own with time. The body is an amazing thing, especially in the cardiac system. But what anticoagulants can do is they can help you so you don't form more blood clots. Because if you already have one, you see it shows that you're probably at risk for them. So we don't want more to form in things like that. But they can't stop it from traveling. They can't stop it. They can't change it all. All it can do is stop you from making more. So let's look at these. So probably one of the most common used anticoagulants is what's going to be known as warfarin, also known as Coumadin. This has been used for years, a long time. It has a lot of drug interactions and another downside to it. And I guess I don't even think I explained this, in my class, and they probably thought this was some sort of weird meme. But the reason I have this this picture here is warfarin actually used to be like rat not even used to be, I'm sure it still is used as like rat or mouse killer. And so in other words, what this does is if you take too much of it, you can bleed to death, but they would give it in pellets if they were having trouble, like a rat problem. They could spread it out and the animals would bleed out and things like that. And that's how they would take care of the pest problem. I'm not saying my opinion on this, so this is not a controversial issue or anything like that, but I'm just letting you know. So that's why if you ever hear a patient say, especially older patients, sometimes you're like, oh, hey, I'm here to give you your warfarin. They're like, oh, you mean my rat poison? If they say that, that's why they're saying it. Anyway, so another thing to know about warfarin is this is one of the oral medications we're going to give. A lot of the others we're going to talk about are going to be shots or infusions, but this is an oral option, which is great. When you think oral, it's something a patient can go home on. But a downside is oral medications can sometimes take a while to get working in your system. So this can take 48 to 72 hours to really start working. So usually what we do in the hospitals, if a patient comes in, they have an acute blood clot, I'll start them on like a heparin drip or something else that's going to be quicker. And then I'm going to start them on the warfarin or the Coumadin. And then, I'm going to, as I'm going to be checking certain labs here, we're going to talk about in a second. And once they're getting in the therapeutic range, then I can start weaning off of that heparin so that they're, they have the right amount of anticoagulation on at a time. Anyway, so remember I said that each of the labs I talked about, there's an INR and then there's a PTT, with those, you want to connect it to the right medication. So INR, the only time we're going to care about an INR on a nursing school exam, I don't want to say such a grand statement. The only time we're going to care about an INR on a nursing school exam for this section at my school, almost to keep it with that, is going to be related to when someone's on warfarin. So you really want to think, what do you call it? It's almost like if you look at the end, there's RIN. It almost has, it's RIN instead of INR. Maybe that can help you remember it. If you can't spell like me sometimes, it'd be perfect. But anyway, INR is related to warfarin. So like if there was a question that said, hey, a patient's on heparin, and their INR is something, it don't matter because INR does not measure how effective heparin is. It measures how effective warfarin is. So INR is only relevant to warfarin. So this has that range of 2 to 3. And remember, if it's less than 2, I'm leaning where it's taking less time to clot, so I'm more likely to clot. Whereas if it's greater than 3, it's taking more time to clot, so I'm more likely to bleed. There's two antidotes for warfarin. One is vitamin K. The other is going to be FFP or fresh frozen plasma. Both of these can reverse it. So sometimes patients come in and they need a procedure or something else done. And so we can actually give this, and vitamin K is super expensive. So usually we go the FFP route. So we usually give them a bunch of FFP, or if someone comes in, their INR is really high, we can give this to reverse it as well. But if we're going to do a procedure or surgery and we need their INR lower so that we can safely cut into them, this is sometimes what we'll do too. Anyway, so teaching. So sometimes there's confusion around this. So there's like, mixed stuff that says like, hey, don't, do vitamin K foods. Absolutely. We don't want to be sitting here getting crazy with our vitamin K. But if my body's already used to a lot of vitamin K, if I am just a little rabbit eating away at my salads constantly, I should keep with whatever I'm doing. I want to keep with what my body's used to, but I don't want to drastically change my diet. And, I brought up in my class about how sometimes patients, they get a blood clot and they're like, oh my God, I'm so unhealthy. I need to eat healthier. So they'll start eating really healthy suddenly. Well, we don't really want to do those changes. We don't want to dramatically increase green leafy vegetables because that can actually make it where my warfarin is not therapeutic, which means, remember, if it's not therapeutic, if it's too low, I'm leaning on the clotting side where I'm more likely to clot because I'm literally giving the reversal agent for the warfarin just in my diet. So we want to keep a consistent level of vitamin K in their diet, whatever they were doing before. We want to keep it consistent. And then be careful with other drugs, not drugs. I don't know what drugs are, but drugs that can cause bleeding. So we want to be very cautious with there's a lot of supplements and herbs and stuff like that that can be more likely for bleeding to occur. And then there's also things like alcohol as a natural anticoagulant. So unfractionated heparin. This is something you're going to see very commonly given to if you're not of a patient. A patient in the hospital is most likely on this because the cool thing about this med is that it has a very short half-life. And what that means is that it can be in and out of your system pretty quickly. And this is really ideal when a patient's in the hospital because sometimes I want to bring them to surgery like on pretty short notice. And so I can stop this and it can be out of their system pretty quick. We usually give heparin like in 3 times, like they get the dose 3 times a day. So they do need more doses of it because it lasts in their system longer. Or when patients have like an acute problem, like an acute blood clot, that's also when they'll get they might get IV. So usually we only put people on IV heparin if they have an acute issue, like they have acute AFib. There's no time that they're going home soon. So we might have like they have an acute dysrhythmia like AFib that's causing them to be at risk for blood clots. Or if they're maybe going to go to procedures or surgery, want to be able to turn it on, turn it off, things like that. Or if they just need we need to really keep a close eye on it. So if someone is on sub-Q heparin, like they're just getting the shots 3 times a day, they actually don't need any therapeutic monitoring. So we don't need to monitor any specific lab when it comes to like an INR PTT. There are other stuff we want to look at for all patients, but I'll talk about that in a minute. But the only people that really need regular therapeutic monitoring for, PTT and stuff like that, which is the lab connected to heparin, by the way, are going to be people that are getting IV heparin. So if I'm getting IV heparin, it's continuous in their bloodstream. With the sub-Q, it's kind of slow release. So it's not slow release, but slower release. So there's less concern. I do not need to check an APTT for someone on sub-Q heparin, but when someone's on continuous, I need to make sure that they're getting enough, but not too much. So again, we have this 70 as the high, and if I'm getting above 70 seconds to clot, then I'm going to be more likely to bleed. And then on the opposite end, if I am taking less time, less than 46 seconds to clot, I am clotting more and I am at risk for clots. So the same thing goes, like I talked about INR for warfarin. The PTT is the same for heparin. In that if I gave you a problem and said, hey, a patient's on warfarin, their PTT is this, it doesn't matter. PTT has nothing to do with warfarin. It only matters for IV heparin. So you just want to always be very careful in your in the test question and read what med are they on and what lab is related to it. Is this the lab that even matters? There is a reversal agent for heparin and also for low molecular weight heparin that's known as protamine sulfate. So if they have too much, you can give it. So there was one time that had a new grad nurse who she had a patient on heparin drip. Everything looked good, checked it off, but there was a pump malfunction. Somehow it managed to drain the entire bag into the patient within like an hour. And so something that they should have received like that dose like over days, they received in like an hour or two. As a result, like their PTT was like undetectable. It was so high. So we had to give them a lot of protamine sulfate, but it does do the trick. Other signs of a problem. So remember I said all these patients, you know, for warfarin, heparin, et cetera, they all are going to be risk for bleeding, but what's different? So especially with long-term use, heparin can lead to osteoporosis. And there's also this special syndrome that's what's known as HIT or HIT. And it's what's happening is in the body's having an overreaction to the heparin. And the way it reacts is it starts slashing and breaking down platelets. So it's a thrombocytopenia or a low platelet issue. So remember I said earlier, for patients on sub-Q heparin, I don't need to check their PTT, but on a daily basis for all patients that are on heparin, whether it's sub-Q, IV, or low molecular weight, all patients, I need to check a platelet count on. I need to make sure that their platelets are staying stable. I'll also say for all patients that are on anticoagulants like warfarin, heparin, low molecular weight heparin, whatever, fairly regularly. I'm not saying they don't, when they go home, they're not going to regularly do this, but, you know, I might be keeping a closer eye on their hemoglobin to see if they're maybe like, you know, bleeding internally or having some other issue. So, excuse me, as a whole, you know, when we look at labs, INR is for warfarin or Coumadin. PTT is for someone on continuous IV heparin. Everyone who's on either unfractionated heparin, sub-Q, IV, and we're about to talk about low molecular weight, needs a platelet check in the morning. And then we might want to keep a pretty close eye on their hemoglobin if they're in the hospital, just to make sure that they are not, you know, losing blood somewhere. The other thing real quick I want to say about heparin-induced thrombocytopenia or HIT, and I'm sorry I'm dying because these back-to-back lectures always get me dry. The other thing I want to say about HIT is there's low platelets. You'll notice that, you know, remember the normal platelets, 150,000 to 400,000. So you'll start to notice a decline in your platelets, and it's usually going to be pretty rapid. And they usually, what they have to do is switch them over to a, non-heparin anticoagulant. So usually they'll switch them over to this medication called argatroban. So there's also low molecular weight heparin. I said earlier, remember the L in this as long acting. So this is the same, it's a heparin product. This is probably one of the meds you're going to give, super common in the hospital, but what's different is that it lasts longer, has a longer half-life. They are less likely to get the complications of the heparin-induced thrombocytopenia or osteoporosis. And the other pro is there's no therapeutic monitoring. So this is just like the sub-Q heparin. I don't need to monitor anything. There's no PTT, there's no INR. The only thing I'm going to look at is my platelets. And again, I might keep an eye on my hemoglobin, especially if I'm worried about bleeding in the patient. They have the same antidote. So the only thing that's really different is that they have less dosing. So the sub-Q heparin, they need 3 doses a day. With low molecular weight heparin, sometimes they can get 1, or you know, sometimes they need 2 doses a day, depending on their weight and the problems they have. But yeah, so they get less pokes, less shots, less monitoring, less complications. So that's why this one is definitely a go-to. It just depends on doctor preference, etc. There's also some new age oral anticoagulants, and this is going to be stuff like dabigatran, rivaroxaban, or apixaban. You know, and here's some like little mnemonics. I mean, keep in mind with all of these, they have the benefit that there's no monitoring that needs to be done, just like with the low molecular weight heparin. But the other disadvantage, they're more expensive. Now, sometimes in the hospital, they'll give all these vouchers and stuff for them, so people can afford them for a while, but long-term, it can be hard. So it really depends on the patient, their insurance. But a lot of times these are preferred because there's less monitoring. Keep in mind with the patient on Coumadin, they have to go get their blood drawn pretty regularly. So, you know, that can definitely lead to a problem with compliance and an issue with really keeping up with the maintenance of their medication. So you want to keep in mind that we want medications that are going to help the patients and are effective, but we also want medications that are more easy to be compliant with. So stuff like this can sometimes, there's a lot more compliance, when as a result, I'm sorry, my cat's getting needy. There's less, because of the less need for monitoring, patients are going to be more likely to keep up with compliance. Here, I'll say. All right. So let me move the ability for her to beg at my feet. Anyway, these medications, like years ago, they were less safe because we didn't have any reversal agents, and we have no way to monitor them, so we didn't know if they were getting too much. But with time, there's been reversal agents for all of them that have come about, and they're definitely better studied and better understood. There are some labs we can do to kind of look at how they're doing, but you don't have to know them, especially not at this level. One day, if you become a prescriber, you can learn it, but for now, keep it simple. So overall nursing focus, if someone has a blood clot, is that we want, of course, first and foremost to prevent it. So as the nurse, I'm always trying to prevent blood clots. Like I do this through, people have the DVT prophylaxis and stuff to prevent clots in the first place. That's why everyone in the hospital is more immobile. So everyone in the hospital gets anticoagulation. Other things I can do is the compression. So remember, the things that help with venous are compression, elevation, and movement. So I want the patient to move, do exercises. Leg exercises can be like foot pumps. Sitting, pumping their ankles is super helpful. And then additionally, we could making sure that if a lot of times if they're especially if they're not as mobile, I want to kind of put a machine in the place of their muscles that aren't working or not moving, and use like an SCD machine. That's a sequential compression device machine. They can also have TED hose on alternatively. There's foot pumps, things like that, that can all provide compression. But effectively, I want to find some way to provide compression. I want to encourage them to move or do leg exercises when they are in the bed. Some of my priority stuff is going to be looking if the clot has traveled. Again, I can't get rid of it by myself or on my own willpower, but it's going to have to do its thing on its own. But I do need to check to make sure it's not getting worse, new clots forming, or clots traveling. Like I said, encourage them to move. The one thing that you don't want to do when someone has an acute DVT is you don't want to massage it. So I said earlier, for prevention, we want to do compression, but no, for when someone has an acute clot, I do not want any massaging of the legs. It might hurt, and the patient might say, oh yeah, massage my leg. Nope, I'm not massaging your leg. That can migrate the clot. We also don't want to put like a blood pressure cuff or SCD usually on that side. It doesn't mean they can't have SCDs. I can put one on the other leg that there's no clot in. I just don't want to put one in the leg where there's a clot. And that's usually just in that acute period. It's not that they can never have SCDs again. I want to watch for trauma injury, any signs of bleeding, making sure there's nothing new or different coming up, because that's a complication, of course, of the medications. Because with these patients with anticoagulation, it happens all the time. Patients come in and they're on anticoagulation, they're not forming clots, but then they fall down and end up bleeding, which is why all doctors have to look at with patients like risk versus benefit. I had an uncle who had a blood clot, and like with him, they decided risk versus benefit, start him on the blood thinner. Within a week, he was he fell down and hit his head and got like a huge head bleed. And so with him, eventually they decided, no, we're going to do a the IVC filter or the vena cava filter, because with him, it was like they couldn't keep him on the anticoagulant because his brain was bleeding. So it was a whole thing. It's always a hard risk versus benefit. Sometimes people get to a certain age where they're more at risk for falling and dying of the bleeding from their brain in the fall than they are of getting a blood clot and having a complication from that. So the doctors always just have to look at risk versus benefit. If there is serious bleeding, we want to give the reversal agent, but we want to always keep in mind, let's say, okay, I have a patient on heparin. You have to think about, okay, what is the medication the reversal agent I would give? The opposite of heparin is the protamine sulfate. So if I gave protamine sulfate to a patient, like that patient that I talked about, that the new grad nurse accidentally, something went wrong with the pump and a whole bag went in, I give the reversal agent. What am I worried about? Well, I'm worried we're going to get to a point, I want that level down. I don't want them bleeding to death. But if I reverse it, what do you call it? They're going to be more likely to, remember, because we're over here, we're bleeding too much. Then if I give the reversal, it's going to put them in the other direction where they're more likely to clot. So I need to be watching out for that. Pain management. And a lot of times what can help these patients, and it's a common misconception, people always think that with DVTs, you can't elevate their legs because it, like I'm sure, and you're going to see questions out there. It's a misconception that someone with a DVT, we don't want to elevate their leg because it just gives a straight shot for the blood clot to their heart. But it actually can decrease some of the swelling, relieve pain, and be very helpful. So you can elevate their legs, especially if the edema is severe, and we might put them on bed rest, but you still want them to be doing those foot pumps and other things. Even if they have the blood clot, they can, on that side, they can still do foot pumps. We don't want massages directly trying to dislodge, but, doing the foot pumps can actually help them in order to make sure they're getting good circulation and things like that. So it's not that we don't want circulation, we just don't want direct pressure right on that spot where the blood clot is. So foot pumps, elevation, things like that, if they have to be on bed rest, to make sure that it can help decrease some of that edema and promote good flow. So now let's get to education and bleeding precautions. So we've talked a lot about bleeding precautions, but you're probably wondering, well, what are bleeding precautions? So the big things you want to keep in mind in general is if someone's on an anticoagulation medication, something else I want to encourage for them, if it's appropriate, depending on their other history, is going to be to increase their hydration, because thick blood, again, is a risk factor for blood clots. But if they have increased fluid intake, it can help to make things thinner, or less thick in their blood, which can help along with the medication. And then some of the bleeding precautions we want to encourage is a soft bristle toothbrush, so that they have less chance of breaking down their gums. Electric razors only, so they have less chance of cutting their face when shaving. We want them to avoid trauma, so like no contact sports, high-risk activities where they could bleed, and then also fall prevention and environmental safety, especially in the older adult, because they're going to be more likely to trip on something and fall. So we want to make sure they're safe, like no extra rugs and other stuff that could cause a fall. We want them to avoid too many sticks, so we want to avoid oversticking them, because that can lead to, more blood loss, and we want to minimize the sticks as a whole for these patients when possible. And the IM injections, you're more likely to bleed at the intramuscular level. If bleeding does occur, we're going to hold pressure for 10 to 15 minutes over the site in order to make sure that the bleeding is going to they're gonna, remember how we count those seconds, how long it's going to take them to bleed. They're going to be more likely to bleed for longer, so we want to hold more pressure. So this is what I always tell students, like if you're going to take an IV out, like you get so excited, you're like, oh my god, I get to do a skill. Just make sure to always ask the nurse, like, hey, are they on anticoagulation, antiplatelets? You might just need to hold pressure for a little bit longer. Excuse me. They should report any bleeding. So I talked earlier about different places you can bleed. But you want to think about any place you have a hole. People talk about bleeding from the eyes, not likely, or bleeding from the ears, not as likely unless you're in like DIC, and that's really bad. But the most common places you're going to want to look for and assess for or ask about is the nose. They can get nosebleeds, and the mouth or the gums, where when they brush their teeth a little too hard. They can have hematuria or pee out blood. They can have black tarry stools. They can have bright red bleeding from their stools. So we want to look for signs of either digested blood, which is the black tarry, or we want to look at the bright red could be something like they have a hemorrhoid or something that got torn, like they're just like very sensitive. There's a lot of blood vessels around the anal area. We also want to look at like GI bleeding, like if they have, again, coffee ground is partially digested blood, or bright red bloody vomit. That could be GI bleeding as well. And we will look for signs of them bleeding inside. And this would be stuff like they are, sorry, what's that? Drinking cold water. Sometimes it gets me all going. Too much talking. Anyway, The internal bleeding, you would want to look for signs that they're bleeding inside. So some of the most common ways that I know someone's bleeding inside is they either have, they can have like changes in their vital signs, like a decreased blood pressure, high heart rate. They could also have changes to their hemoglobin, with their hemoglobin dropping. It is possible you could visually see changes. Sometimes there's abdominal distension, stuff like that. It depends on where they're bleeding. But sometimes the bleeds are slow. So we're going to look for changes in vital signs, look for changes in hemoglobin, things like that are some of the big ones. We already kind of talked about there's other meds like herbal supplements and stuff like that that can cause you to bleed. And then alcohol is also a natural anticoagulant. As a whole, I want them to do things to avoid bleeding happening. If they do have to bleed, I have to take an IV out or something, hold pressure. Less sticks is better. Look for bleeding, and then avoid other things that are going to, make this worse, and hydrate to help. All right, so let's do some scenarios. I think these would help. And then this is the last thing, because I know this is another long one. The two big topics in vascular are going to be PAD and DVT. So let's look at these scenarios. Remember, we always want to look at the med, the lab, and does it match? Like, is it the right med for the right lab? And then then we look at the lab. What's the normal? What side are we going through? So we want to look at each of these and see, is the lab value appropriate? Is it a sign of a problem or not applicable? And if it is a problem, what are we going to do about it? So first is a client on warfarin with an INR of 2.6. So first we want to see, okay, warfarin. Yes, that's an anticoagulant. Second med, our second thing is the lab, the INR. So a patient that's on warfarin, what lab is connected to warfarin? Remember the RIN at the bottom, or at the end of that is also, you could rearrange it, and warfarin is connected to INR. So this is the right med with the right lab. Now let's look at the lab. It's 2.6. Remember, I don't care what normal is. I want to see if it's therapeutic. Remember, therapeutic is 2 to 3. So where are they in there? Are they in the therapeutic range? They are. So if I have a patient who is on warfarin, I check their INR, it's 2.6. That's therapeutic. Do I need to do anything? The answer is no. This is expected. This is good. I want it to be therapeutic. This shows that they're not really super high risk for clotting. Bleeding is this side. And then they're also getting enough where they're not going to be clotting as much. Now I have a client on a heparin drip and a PTT of 35 seconds. So first heparin drip, okay. PTT, are heparin drips and PTT connected? Yes. Remember, PTT, the only time I really need to check this, I didn't really go in depth in this earlier, but there is an APTT and PTT, but just know, like, for our class, our school, what we say is 46 to 70 is per the book. Know in the hospital that every protocol and stuff's different. What they might want you to stay in will be different depending on the patient, and again, whatever protocol they're going by. But for this testing purposes, 46 to 70. And we're not going to give you some trick where there's an APTT or a PTT. Just always know 46 to 70 if you see something with PTT. Anyway, client on a heparin drip. And so heparin drip PTT, so these are connected. It's 35 seconds. So the normal is 46 to 70. So I am below. I'm hanging on this side. I'm low. So remember, if I'm low, it's taking less time to form a clot. So if it's taking less time to form a clot, I can form more clots. So the patient probably needs an increase in their dose to get I don't want to go too far this way, increase in their dose to get them in that therapeutic range. And one thing I do want to note is there's also a lab called a PT, and it's usually like when you see the INR, you're going to see PT INR. We don't really look at the PT very often for any patient. The only two labs you need to know about is specifically the INR and then the PTT. Just always make sure, because sometimes those tricky nursing professors like to put a PT instead of a PTT. So always make sure that there's double T's. All right, the next one, the client is on apixaban and they have an INR of 1. So we look at the medication, apixaban, and then I look at INR. Are these connected? Well, if I remember correctly, all the ban medications, these are the new age oral anticoagulants, they don't need any therapeutic monitoring. So their INR of 1, that's a low INR, but I have to remember, wait, apixaban and INR aren't even related. So this one is not applicable. It doesn't matter if their INR is 1. That's not what I'm using to see how it's doing. Remember, there's no therapeutic monitoring. So this one is a null or moot point. There's nothing I need to do here because that lab doesn't tell me how that med is doing. All right, so then number 4, clients on Lovenox, they have a platelet count of 75,000. So this is not a therapeutic INR PTT thing. It's saying Lovenox platelet count. So I have to think about first, is there anything about platelets having to do with Lovenox? So I know that they can have that heparin-induced thrombocytopenia where their platelets can get low, and then I'm worried about that. So then let's look. So their platelet count is 75,000. Normal is 150 to 400,000. So I am low on platelets. So it's possible they could be experiencing that HIT syndrome. So I would want to report this and maybe look more into, we usually draw their blood and see if they have antibodies, that would indicate that they're experiencing HIT, and then change their anticoagulant if it is an issue. All right. Last but not least, client is on a heparin drip and their hemoglobin is 6. So again, this is not a therapeutic monitoring, but this is looking at excuse my burps, that patient's on a heparin drip and they have a hemoglobin of 6. And so heparin and hemoglobin, we have to think about, okay, what's the connection there? So this is why I said when you're studying, you really want to think about what's the connection here. So heparin and hemoglobin, I know that if anyone's on any anticoagulant, it increases their risk for bleeding. So I guess what I would be concerned about when it comes to heparin and hemoglobin, if that hemoglobin is abnormal, it could indicate that the patient's bleeding. So now I look at it, it's 6. So if you remember back to anemia, I mean, in general, 12 to 18 is normal. I know I talk in my anemia, hey, we don't really transfuse until later, but, I'm always keeping an eye on it. Like, because again, anemia can even show up at 8 to 10, but this patient's 6. So they're super low. So this actually happened to me with that patient I talk about for the PAD patient that was going to lose all of her limbs and her digits and stuff. She was on a heparin drip and we'd kind of been watching her. She'd been slowly trended down. And she was hanging at 7.1 for a while, and then she finally got below that threshold and she was at 6.9. So they ended up giving her a unit of blood at the end of my shift. So I'm always looking, once we get below 7, we usually start to talk about transfusing. When it comes to it, what I'm concerned about here, this is a concern. I need to do something. I'll probably report this to the physician. Now, depending on if this is new, different, they might want to stop that drip like immediately. Because if they're on a heparin drip and bleeding, if I keep giving them heparin, they're going to be more and more likely to bleed. You probably want to think about, I also want to identify maybe the cause of the problem. Maybe they're on a heparin drip and it's new and their PTT is super high. Remember, PTT really high, more seconds to start a clot or to stop. It's more seconds to clot, so it's going to take me longer to clot. Therefore, I'm more likely to bleed. So someone on a heparin drip with low hemoglobin could be bleeding because their heparin drip is too therapeutic. It's over therapeutic. But there also could be other causes. But either way, you always look into what is their, are they over therapeutic? Or are they therapeutic? And then where is the bleeding happening or coming from? So you want to look for signs of bleeding. All right. We have made it through the major topics for vascular. We've got a couple small topics coming after this, some varicose veins and phlebitis. Enjoy.